Good morning, good afternoon, and good evening, and welcome to our session on innovation in strengthening health system preparedness to address violence against women. My name is Manuela Colombini, and I'm an assistant professor on health system and policy at the London School of Hygiene and Tropical Medicine. And I'm here today with my co-chair, Dr. Avni Amin, who is a technical officer at the Department of Reproductive Health and Research at the World Health Organization. And we have a very interesting panel session today with 5 different speakers. And the main aim of our session today, let me just, sorry, I'm having some trouble with my session. Okay, so the main aim of today's session is to share innovative system responses to strengthen health providers' capacities and service providers to address violence against women. And these are 3 of the key objectives: to show how complex some of these responses can be and their feasibility, to advance methodological innovations, and also to generate reflection on how innovation can improve women's health and sustainability. So we have 6 speakers and 5 presentations, and I'm going to introduce the panelists now before they will present their findings. So the first speaker today is Dr. Flavia de Oliveira. She's a professor of preventive medicine at the University of Sao Paulo, and the medical doctor specializes in public health. She's been working on gender-based violence and primary healthcare responses since 1994, and she was co-PI of the Brazil study in the WHO multi-country study on domestic violence against women. And she's the PI, principal investigator of the HERA studies in Brazil, which she will present today. The second speaker is Dr. Ana Batista, and she is a Mozambican physician with 12 years experience working on GBV programming in Mozambique. And currently Anna is team leader overseeing JAPIGO's GBV portfolio, providing technical leadership to the DREAMS initiative for HIV and violence prevention among adolescent girls and young women, and to the World Bank Sexual Exploitation and Abuse Mitigation in Development project in Mozambique. Our third speaker is Dr. Abdusalam Al-Kayat, and Abdusalam is an assistant professor in the Public Health Department at the Faculty of Medicine and Health Science at An-Najah National University in Palestine. He has conducted research on domestic violence in relation to health system response and capacity, and gender as a social determinant of health. And he is the co-principal investigator of HERA studies in Palestine. Our fourth speaker is Dr. Sanjita Arora. She's the research officer at the Center for Equity Inquiry into Health and Allied Teams in Mumbai, and has led the implementation and research study on system responses to violence against women in collaboration with the World Health Organization. And she will present with Dr. Srinivas Gadappa, who is the head of obstetric and gynecology at the Aurangabad Medical College, and has contributed to developing and implementing the respectful maternity care intervention in the hospital. And he's also the lead trainer for health professional in the hospital for the research study in India that he will present. And lastly, we have our 6th speaker is Dr. Sharifullah Akmal, and who is a National Professional Officer for Gender, Equity and Rights Program at the WHO Kabul, Afghanistan office. And he has led the implementation of a 5-year GBV treatment project, protocol project since 2015, that has been to be scaled up in 34 provinces in Afghanistan. So it's a very interesting and diverse panel. The structure of the panel very briefly, so I'm going to shortly to leave the floor to my co-chair, Dr. Avni, Amin, and for a poll on the role of the health system responses. And then we'll have short, brief opening remarks on why the health sector response is needed by me. And then we start our presentation. And there will be a Q&A at the end. Hopefully we'll have enough time to answer to your questions. And please do post all your questions and comments into the live Q&A on the on-air platform on the right-hand side of your screen. And thank you very much. And now enjoy the session, and I leave the floor now to Dr. Avni.
Thank you, Manuela. So I just wanted to start before we get into the panels, to start the session by doing a short poll of questions related to health systems response to violence. If you're on the on-air platform, I'm going to start the poll one by one and ask all of you to put in your responses. And at the end of all of the 3 questions that we will answer, we'll just do a short debriefing of those answers. So I'm starting the first question, which I'm going to read out. I hope all of you can see it. The first question says, which of the following are the roles and responsibilities of healthcare providers to respond to violence against women? Select all that apply. If you can go onto the poll. I'm just giving a minute, a few seconds for people to answer. Super. Okay, now I'm going to start the second one. Applying a gender-sensitive health response to women experiencing violence requires that health providers insist on women disclosing whether they are living in abusive relationships. Is this true or false? Okay, I think most people have answered this. I'm going to now start the third question, and I'll read it out. Making the health system ready to be able to provide care to women experiencing violence minimally requires the following, and select only one option. The first option is having a private space, confidentiality mechanisms, and trained healthcare providers. The second option is having all services that are needed by the survivor, including police, legal, medical, psychosocial support, under the same roof. Okay, so I'm just going to run through through each of your responses and share with you the results. The first one shows basically that 25% answered the question, refer to other support services and resources as needed. 25% of you said do no harm. None of you selected the option make decisions for women who are unable to or unwilling to make decisions for themselves. The fourth option, 25% answered the question of provide first-line support. And the fifth one, which said mediate between the couple to resolve the woman's problem, no one answered that. And 21% of you said provide clinical care. So the correct answers, and I think everybody got all the correct answers, which is the first one, second one, number 4, and number 6. WHO's guidelines recommend basically that as part of the survivor-centered approach, healthcare providers have a role and obligation to provide referrals and support to other services as needed. The do no harm principle applies. WHO's guidelines recommend provision of first-line support to all survivors who disclose violence. And of course, the provision of clinical care is there. The two roles and responsibilities that are not actually ones that healthcare providers should be doing is making decisions for women. The principle of autonomy and women's rights to make autonomous decisions stand even where providers don't agree with the decisions women make. And of course, we don't recommend mediating between couples, partly because the woman's disclosure of violence should be treated confidentially, and healthcare providers should not necessarily talk to the woman's family about the violence because it can jeopardize her safety. The second one, all of you got the answer correct, which is false. The correct answer is false. What WHO's guidelines recommend is to inquire about violence where providers have a reason to suspect violence, but if the woman is unwilling to disclose, then the provider should just offer the information about the health consequences of violence, offer a follow-up appointment, and let the woman know that any disclosures of violence will be handled confidentially, so that eventually there is trust in the provider. And the third one, which says making health systems ready to be able to provide care to women experiencing violence. The results say 60% of you answered the minimum requirement as number one, which is private space, confidentiality, and trained healthcare providers. And 40% of you answered the second option, which is having all services needed by the survivor in one place. And here the correct answer is actually number one, which is the minimum requirement, having these three things: private space, confidentiality, and trained providers. And the reason is that there is no evidence that shows that having all the services under one roof is better than a model which is integrated into the health services. It doesn't mean that that shouldn't be there, but that is not a minimum requirement. The evidence that one-stop crisis centers, that is having all services under one roof, are more effective, provide more quality and more cost effective, is still not there, because a lot of the one-stop crisis centers haven't been evaluated. So I'll hand it back over to Manuela to lead us through the panel. Thank you very much.
Thank you, Avni, and welcome back. So let me share again my screen. Okay, so very briefly, just a few points about why health system responses to violence against women is needed. So over the last 25 years or so, violence against women, in particular intimate partner violence and sexual violence, have been increasingly recognized as a human rights violation and the public health problem. So violence is prevalent and globally. So worldwide, more than one in three women experience intimate partner violence or non-partner sexual violence in their lifetime. And these are global estimates and been published in 2013 by the World Health Organization. So the violence is deeply rooted in gender inequality and has severe consequences for physical, mental, reproductive health and well-being of women and girls, hindering achievement on other social and economic goals as well. So for instance, compared to women who didn't experience violence, women who've been victimized have more physical symptoms or more likely to experience depression, anxiety, acquire HIV, and access services more often than non-abused women. And the kind of another important reason is also that the health system is a crucial entry point, so health facilities, especially for women in general, because at some point they will access health services, whether for family planning, for child immunization, etc. So a health system response is now a global priority. So there are global WHO guidelines, clinical guidelines, system health guidelines for health managers. There is a global action plan on violence against women. So there are recognized advantages for such a response to which include the better and more women-centered or survivor-centered care. So for example, if providers know about the history of violence, they can offer better care tailored to women's needs, or an empathetic and supportive response from a well-trained provider can also act as a turning point in terms of safety and healing for the survivors. But despite some of these recognized advantages, of course, many countries are still struggling with implementing such response, especially in low resource settings. So for instance, health providers are not able or willing to detect response abuse, or some of the encounters between the providers and the women exposed to IPV are not always satisfactory. So to integrate a health system response is it's complex. It's not just a one session training, but it actually needs the whole system to be ready. So not just the training. So it's a concept of health system readiness. And health system capabilities go beyond the availability of some of the material resources, so including budget, infrastructures, and technical capacity of the providers, but it also includes some of what some of the kind of health systems researchers have talked about, is software dimension. So these are less tangible resources, including the values of the stakeholders, the providers, the women, the confidence and the motivation and the trust also the women have in the services, in the providers, linked and the important link between the health system and also the clients and the community, which is a link that has not yet been further, well developed and researched. And this allows a more people-centered approach as well for such a response. And lastly, the health sector is not alone. So a health system approach also has to be embedded within a kind of multi-sectoral response as well, thinking about other sectors and the kind of structural context within which the services are embedded. So today we are here to explore the experiences from different researchers, NGO and activists and providers on findings, challenges and lessons learned from some of the efforts to implement some of these health systems innovation to address violence against women, including provider trainers, service providers, and some quality assurance approaches. So I will then, I'm very pleased then to actually open the floor and introduce you to our first speaker, Dr. Ana Flavia Oliveira, who is going to talk about some of the findings of the HERA study in Brazil.
Okay. Good morning, everyone. I am Ana Flavia, and I'm here based in São Paulo, Brazil. Manuel, I can't see the PowerPoint. Do you think everyone can see it?
Oh, we are not seeing. I don't know.
You are not seeing as well, yeah?
Manuela, could you share your screen again?
Or I can share mine. Let's see. I'll try to share mine. Oh. Okay. Okay. So today I am here. I am a medical doctor. I work at the medical school here in São Paulo, the University of São Paulo, and I will share with you the part of the results of the HERA Global Health Group, that stands for Healthcare Responding to Violence and Abuse. We are an international group. We are led by our colleagues in England, Professor Jean Feder, Lorraine Bacchus, and Manuela Colombini. And we work with colleagues on occupied Palestinian territories, and Professor Aboud would be here with us as well. I am in Brazil, and I will present part of our work with you. Yeah, we are in a big city. Manuela, can you change the slide? We are in São Paulo, and São Paulo is a more than 12 million inhabitants city. 1 in 3 women in São Paulo ever suffered physical or sexual partner violence, and we have a lot of contrast and inequality. The aims of the study I will present here to you was the HERA 1, as we call. We are now in HERA 2 with Nepal and Sri Lanka colleagues as well. And we try to understand how primary healthcare systems can develop and evaluate interventions for domestic violence against women that link with community services and ultimately ensure better health outcomes for women and their children. We will focus here in the readiness of primary care services to identify domestic violence against women, and how we use readiness to develop the intervention in agreement with all the stakeholders. So we will focus on this. This is a multi-method study looking at before and after an intervention built based on what is already in place. And I would like to highlight this important thing of looking what is in place before you try to integrate any new intervention. Yeah. And we will focus in this presentation on the readiness study of the health system. That is the formative research study that is highlighted in red. We studied in this pilot study 2 primary healthcare clinics that have more or less more than 100 healthcare providers each, because it's a huge city and you see huge health care clinics. First, what we did first is to look, yes, you can change, to look at the policies, previous one, the policies already in place in Brazil and in the city of São Paulo. So you can see that we had in Brazil a lot of policies, written policies on domestic violence or sexual violence. In green, you can see the policies from the health ministry or municipal health department. And in lilac, you can see the policies from the violence against women specialized services. So we have all these policies in place, but to study and know the laws and policies are not enough to understand the readiness of the health system. Because if you look here, you said, oh, Brazil has a lot. Yeah, we needed to observe and understand how these policies are translated in real services and practices at the ground through facility observations and managers and health providers semi-structured interviews. So these are the techniques I showed in the formative research. So I would like to show you, because this is a very brief presentation, the main results of our health system readiness study and how we plan to overcome them in the intervention we proposed. So we organized this using the WHO health system building blocks. And I want to highlight the importance of governance and leadership and financing in the key barriers that affect the system readiness. So managers did not prioritize domestic violence and had to meet strict productivity goals that are tied to payments. These productivity goals disencourage managers and professionals to dedicate time to domestic violence, which is not in the goals and is perceived as a time-consuming work. We found the policies directed to domestic violence care were loose and broad. And to overcome that, and it's loose and broad because it's not prioritized, yeah? To overcome that, we encourage the managers to participate in the intervention and the training. We made very clear and detailed guidelines and flows, and we distribute this material in the training. We try to make the response we taught simple and quick, using role plays and discussing the myth that hours are needed to do this work with violence against women, and especially domestic violence here. We also discussed the opportunity to include domestic violence identification as one of the productive goals. However, caution is warranted, as overzealous action by untrained healthcare providers can jeopardize women's safety. So this is a tricky question, and I think we can discuss this better later. Next slide. The next block of system readiness barriers are related to health workforce, service delivery, health information, and coordination. These loose and broad policies were translated in lack of clear protocols, flows, and professional roles, weakness or confusion on the activities proposed by the policies, fear and lack of empathy with healthcare providers, blaming the victims. We address these barriers, reinforcing the standard operational procedures, flow, and each professional's role agreed with stakeholders and everybody in place. We also used interactive games to put healthcare providers in touch with women's difficult decisions and put themselves in her shoes. We also trying to put this NPV group, that was the specialized group proposed by the policies, in contact with the multi-sectoral network in order to enhance the collaboration and diminish the lack of knowledge and trust from healthcare providers in the multi-sectoral network. I will show to you the flow that we proposed. This is the flow, and the important thing here is that women could disclose to any primary healthcare providers, but we trained internal specialized providers from the NPVs to do a more detailed counseling to these women, and the external referral are done just after a more detailed talk inside the healthcare. And we raised the identification in the end, in spite of this being a very small pilot. But we also know better now why it raised. You see, time constraints and fear were diminished and a more clear flow established. Healthcare providers feel more confident and just judge less women. However, the end of Women's Special Secretariat in federal level and municipal level, the cuts in the budget to tackle violence and the cuts in the budget to the health system, and more recently, the COVID pandemic, has been making even more difficult the sustainability of interventions proposed and the implementation of the policies on violence against women and primary health care. Sorry for the run. I hope we can discuss more, and I finish here. These data are published in the second paper here in bibliography to the ones who want to know more. Thank you very much. It's a pleasure to be here.
Thank you. Thank you, Ana Flavia. And now I would like to call Dr. Anna Battista, our second speaker, to talk about the GBV quality assurance tools that they implemented in Mozambique. Anna, the floor is yours.
Thank you, Manuela, and hello, everyone, once again. I'm here, I'm Ana Battista. I will talk about the implementing GBV quality assurance tool to improve health response to GBV in Mozambique. Next slide, please. Well, just to introduce Mozambique health system. Mozambique is located in sub-Saharan Africa with almost 30 million inhabitants, but the health system is fragile, affected by poverty, conflicts, natural disasters, and under pressure due to infectious diseases that are more common in our public health in our health system, especially on primary health care, which is HIV, TB, malaria. But we have several challenges putting in place our policies on GBV in our health system, but I will highlight some of them, such as staffing and system limitation, inadequate resource monitoring system, lack of multi-sectoral approach to achieve health outcomes. Next, please. So these results are coming from SARA, which is an inquiry led by WHO on the health system in Mozambique in 2018. Thinking in our context, with all challenges and strugglings on implementing GBV services in a very difficult setting as health systems in Mozambique. In 2012, JPIGO and Minister of Health started implementing an holistic approach to strengthen response to GBV in health system. This was based in standardizing all procedures, translating policy into standards, and made them available to implementation at the primary level of services. So this checklist was originally developed by JPIGO Mozambique, but was taken to another level with reviewers from PEPFAR, from CDC, from WHO, and a huge range of international organizations have contributed to refine this checklist and came into the quality assurance tool. Next. I see this tool has, Anna Flavia said, translate policy into action, into real impact on the survivors' lives through the interventions of standard-based evidence in the primary health care, not only at that level, but the GBV quality assurance tool is a straightforward to start, strengthen, and expand post-GBV health services through use of evidence-based standards. But it's not only related to health system. It's the tool looks holistic into the whole multi-sectoral GBV network, putting in place all stakeholders with the same goal, which is of offering survivor-centered service delivery with minimum quality of standards of quality. So the tool is available in a full version and a minimum version. You can access in the WHO page. Next. The objective of the tool is to help providers and managers to understand and apply the key components of high quality post-GBV care and measure this progress and compare between facilities, districts, even with between countries. So these standards are prepared to rate a health facility from 0 to 100% to see what are the gaps that need to be reduced or eliminated in service delivery and create action plans for quality improvement. I always say that the action plan is the heart of the approach, where all the stakeholders are coming to one consensus to implement a continuous quality improvement continuous action plan. Next, please. So the use can be used to perform external assessment, verification assessment, self-assessments, and external assessment also to recognize improvements, peer-to-peer assessment for case review, for example, and monitor what is happening in each health facility, in each district, in each province, even in each country, based on these standards that were set. Thank you. Next, please. Well, taking into account that Mozambique has been implemented this approach since 2012, but now we have a brand new quality assurance tool in the country. We could manage to identify most frequent gaps that represent barriers for quality improvement for GBV service delivery. For example, limited follow-up of sexual violence survivors. Most of survivors are not coming back to the health systems. So we have to ask why, what is happening, and set strategies to improve this follow-up. Poor child communication techniques among GBV providers. There is a very limited skills among GBV providers to when we're dealing with child survivors. Lack of skills to perform GBV inquiry when it's needed according to the WHO recommendations. Lack of medicines, for example, for hepatitis B vaccination, STI prophylaxis, and this is most common, that not all health facilities have essential equipment for post-rape care. Next. So with these most frequent gaps, we can rely on an action plan that selected the most frequent gaps across the country, and then can lead us to implement interventions that can have impact on the health system. So when we see our action plans being implemented, not only on paper-based, but recently Mozambique have come to an electronic GBV quality assurance tool that allow us to have an action plan that can be viewed in real time by multiple stakeholders. The action plans, when we address these action plans, we see capacity building and motivation and advocacy growing, connecting survivors to legal support and shelters and other community resources that weren't available previously, because there was not such coordination between multiple stakeholders being strengthening. And also, the impact goes beyond the health facility with community interventions like home-based visits to improve follow-up of sexual violence survivors, especially children, increase of availability of services, drugs, and also improve respectful and victim-centered communication, especially for children and adolescents. Next. I will finish with some improvement areas that can be implemented, saying that, viewing that the GBV quality assurance tool is a live process. It's not a finished document. It can be adapted to any reality. There's a need to improve mapping, information and education, communication materials. Forensic examination is one of the weakest parts of our process. Care for people with disabilities, include GBV in emergency. It's a huge gap also that we should tackle, and also GBV restriction on GBV services that we are facing now in Mozambique with COVID-19 pandemic. So next. Just to finish, I want to say that implementing GBV quality assurance tool has made difference on how Mozambique, even with a fragile health system, is facing GBV in primary healthcare settings. So Manuela and participants, thank you for your attention. Thank you.
Thank you, Anna, for this very interesting presentation and for showing that even in some low resource settings, things can still happen and some responses can still happening. So it was very interesting to hear about the tool. So now I'd like to give the floor to Dr. Abdusalam Al-Kayat. So we move from Mozambique to Palestine, and he's going to talk about the HERA study in Palestine. Dr. Abdusalam,
thank you very much, Manuela, and thank you everybody for participation. So I'm gonna present today about a brief about our work through HERA project in the occupied Palestinian territory, which I'm leading with my colleague Dr. Amira Shaheen, who's not here today. So as a background, Palestine is one of the country where reported violence by the women and mainly by their husbands are at alert and high percentage according to official numbers. There have been several attempts from the government and from the NGOs to combat that through, for example, establishing a national committee which can respond to that. However, still the response is inconsistent in many ways. Next, please, Manuela. So what we have done in brief, that we have studied to integrate. The aim of our study is to see how to integrate violence against women response through primary healthcare services. To do so, we choose 2 clinics in Bethlehem and Hebron district, which is south in the southern part of the West Bank. And the study consisted mainly of three phases. The first one is the formative evaluation or formative phase, which included many factors related to the health system. And phase two is the intervention development, and followed by evaluation of the pilot intervention using mixed methods. Mainly the formative evaluation phase included, as I said, tools like health system readiness assessment, stakeholder and workshop plan meeting, which absolutely helped in not just gaining information, but also shaping the intervention in phase two, which was implemented. So in a principle, this is our referral pathway for the suspected cases included. First of all, at the primary healthcare clinics, so the training will give the chance for healthcare providers to do a clinical inquiry of domestic violence through the training, where they also can refer this case to what we call a case manager within the clinic, which can offer the first support for the women. If in case is needed, then this case will be transferred outside the primary healthcare clinic at the Ministry of Health Directorate level, which where we have the GBV focal point, which can support in psychological support and social work. However, this is also in many cases was problematic, and I will mention that later. In some cases also, the Ministry of Health may ask for referrals from external support services like police or other social services. With the part of the intervention, which was based on the information from the formative phase, it included also introduction to violence against women to raise the knowledge and explaining what should be the role of healthcare provider, communication skills, code of ethics, and other indicators like identifying, managing, and referring cases of the domestic violence. Also, the safety plans for women and for healthcare provider, and the documentation of cases was also emphasized on. So just in a brief, if I may, list the key findings in positive and negative ways. So what we found from phase 3 evaluation, that on the positive side, that there was more clarity on the rules and responsibilities within the care pathway and among healthcare providers. The role of the clinic case managers was much clarified, and could be responding much better to women choosing not to be referred externally, where we were having the problem, as I said. So we found that women are preferring to be referred or dealt with within the clinic. And this is where we witnessed that internal referral at the clinic during the time of the study was improved, actually. And overall, there was an increased awareness among healthcare providers. On the negative side, there have been many points that we found included the high workload, lack of time, the limited staff protection, which normally would arise from the family of the woman. And there was in some clinics a problem with the private spaces to deal with domestic violence cases. And there was a problem with the documentation system, not only for the sake of the documentation, but many women prefer not to be documented within the logbooks of the clinics due to safety and security issues. So next, please, Manuela. So as you could see, this case study highlights many features, including structure, political, and cultural context that affected healthcare providers' readiness. Also, it pointed to concrete action in the health system level dimensions, including values, leadership, financing, coordination, and information. Of course, many questions still need to be answered, like for example, who will provide that in the clinic in case there is no external referral or women refuse that, as we witnessed, how to address the issue of provider safety, and how to improve the culture or of clinical confidentiality in relation to violence cases, and also the question of improving documentation. To conclude with this last slide, we could see that health system response to violence against women in Palestine is still inconsistent, despite several protocol and policies. There are many issues regarding the referral pathway that is implemented, including documentation, staff protection, and confidentiality. And it should be really clarified, enforced, and implemented in more effective way. And there should be more effort on making violence against women a high priority on both official and healthcare provider level. Thank you very much.
Thank you. Thank you, Dr. Aboud, for this very insightful presentation and sharing the findings on Palestine. So quite different, but some similarities also with the Brazil study presented by Anna Flavia. So now I'm going to leave the floor to our fourth presentation. And next time we move to India on identifying and responding to women facing domestic violence in healthcare settings. And this presentation is going to be shared by Dr. Arora and Dr. Gadappa. So the floor is yours.
Thank you, Manuela. I'm going to talk about an implementation research study that we did, that SEHAT, which is a Mumbai-based research organization, did in collaboration with WHO. Next slide, Manuela. So in 2013, WHO published clinical and policy guidelines to strengthen healthcare providers' capacity and to improve the health system readiness in order to respond to intimate partner violence and sexual violence. And if we look at the evidence in the low middle income countries, there is very little evidence on how to implement these guidelines and what are the adaptations that are required in the context of low middle income countries. And so in this context, SEHAT, which has more than 2 decades of experience in working with the health system to establish a comprehensive response to VAW, we collaborated with WHO to implement an intervention research project in 3 tertiary hospitals of Maharashtra. And the aim of the project was to pilot and assess the uptake of the training and the other system delivery improvement activities based on the application of the clinical guidelines. And what we did is that we created a supportive ecosystems where a systems approach was used to address the barriers faced by the healthcare providers, to build their capacity, to establish the model of care, and to establish the standard operating procedure for responding to violence against women. Next slide, please. Yeah, so just to give you a context, as I told that we did this study in the 3 tertiary hospitals of Maharashtra. And as far as the prevalence of spousal violence is concerned, the national survey indicates that it's 29% at the national level. And in Maharashtra, it is 16% in the urban and 26% in the rural areas. And as far as the policy context is concerned, the Ministry of Health and Family Welfare India in 2014 released the guidelines for responding to sexual violence. But as health is a state subject in India, the implementation of these guidelines is varied. And secondly, there is no national level protocol for health systems response to domestic violence as far as policy context is concerned. Recently, in 2017, the India's national health policy for the first time has recognized the need to effectively, feasibly, and sustainably integrate VAW within the delivery of the health services. So in this context, this project was very important, and that's why we collaborated with WHO. And as this was a pilot, we selected 3 departments, which were emergency medicine, gynecology, and medicine, as most of the women patients, they access health services from these departments, and we started with these departments. Next slide, please. So as this is an intervention research project, so there were certain activities, intervention activities, and one of the first intervention activity that we did was we conducted a 2-day stakeholder consultation where around 30 administrators from the selected sites, they came together, and the purpose of this meeting was to refine the training approaches as well as the system readiness improvement activities. So we use participatory methods like matching the patient flow, identifying the spaces for the privacy, for maintaining the privacy and the confidentiality. So the training approaches and the plan to roll out the intervention activities was developed in consultation with the administrators and the healthcare providers from the 3 selected sites. And after that, we did a 5-day training of trainers where about 26 providers, a mix of doctor, nurses, and social workers, were selected from the 3 sites, and they were trained based on the WHO curriculum adapted in the Indian context by Sehat. And they were also trained to conduct on-site trainings for their colleagues, because the plan was that these trainers will go back and conduct and train their colleagues through a 2-day training. And a 2-day training was conducted by these trainers, and a 2-day training was followed by a half-day refresher follow-up training, on-site training, where the concepts which required more emphasis were covered. Previous slide, please, Manuela. Yeah. And the other activities, the activities which aimed at improving the system's readiness were like establishment of the standard operating procedure. Then we established a referral directly so as to build the capacity of the providers to make the external referrals. We also created some the information, education, communication material, job aids for the providers, and we introduced a one-page registers to enable the healthcare providers to document the cases that they are identifying in their clinical practice, and also what are the services that they are providing. And the research activities were like we documented the stakeholder consultation, and also we documented the on-site trainings carried out by these trainers, that what was the methodology used by the trainers, were the methodology participatory, and what was the content that was covered. And the other thing we did was we did a knowledge, attitude, and practice survey at 3 points. One was before training, before 2-day on-site training. One second was on the second day of the 2-day training, and the third one was post 6 months, to see the retention of the change in the knowledge, attitude, and practice. And qualitatively, what we did is that we interviewed healthcare providers and the women to healthcare providers to assess the usefulness of the training approaches, and women to understand their perceptions about the quality of care. And the last one was that we introduced, as I told earlier, that we introduced registers in the health facility for documentation of the cases. We also did an analysis of these cases which were documented by the provider, to see that what are the kind of the cases that are identified, and what are the services that are being provided by the providers. Next slide, please. Yeah. So I'm going to talk about the training aspect, the innovations that we used in the training aspect. So the first thing is that the on-site trainings were peer-led trainings. So the on-site trainings were basically conducted by the head of the department or the senior clinicians, right? And we found out that there was increased acceptance of these trainings among the healthcare providers. And also, when the seniors were involved, there was an assurance that there will be continuous support from these providers in managing the difficult cases. Secondly, the on-site trainings were conducted in a batch of 30 participants, and it was a mix of doctors, nurses, and the social workers. and which we found very effective. The first thing that it led to was that there was an increased ownership that it is everyone's duty to respond to violence against women. Secondly, it disrupted the professional hierarchies between doctors and the nurses, and also that it's a shared responsibility to respond to women. And then it also led to the clarification of roles and responsibilities. For example, the social workers, they assumed the role of connecting the women with the support services which are outside the scope of the health facility. And the third one was the content of the training that was used. So the aspects like the sex difference between sex and gender, patriarchy and intersectionality were also covered in this training. And we found out that it was very useful because the providers were able to understand that what are the underlying causes of the violence against women. And they also recognize that because of their biases, they are not able to provide a respectful care to the survivors, and hence there is re-traumatization to the survivors. Next slide, please. Yeah. So this graph shows the results of the change in the knowledge, attitude, and the practice. And the scores here are the normalized mean scores at 3 points. One is pre-training, post-training, and 6 months post-training. And if you see that all the three aspects, knowledge, attitude, and the perceived preparedness, which is at the individual level as well as the system level, has increased at the significantly increased at post training level, and there is a decline at 6 months post training. So this indicates that the training on the violence against women should be a regular one. It should be more frequent, and just like the any other clinical training on the clinical aspect. And the second thing is that if you see, the largest change from pre to post training is there in the perceived preparedness. This is because as a part of this intervention research project, we introduced the system level changes like identifying the spaces for maintaining privacy and policy, privacy and confidentiality, creating job aids, and then also the SOPs. And the multivariate analysis of the KAP shows us that the young providers are more likely to have a change in their attitude as compared to the older providers. So this indicates that the training on the violence against women should be integrated early, probably in the during the medical education and the pre-service training. Yeah. So rest of the
Sorry,
slides.
Dr. I just wanted to let you know that in total you just have like less than 5 minutes because we have to also let the last presenter.
Yeah. So Dr. Gadappa will take over from here.
Yes. Next slide, please. Thank you, Sanjida. Now, as a healthcare provider, what we did after doing the training is that all our people who has received on-site training, they started identifying the domestic violence and sexual violence by asking the questions. Now you can see out of 530 in 10 months, 53% domestic violence we could ask by doing the sensitive probing. Next slide, please. Now out of this, you can see that 1/3 of them, they were identified as a violence because they committed suicide or there are some wrist cutting, and remaining 1/3 there was a physical injury. So here we like to highlight that after sensitizing with the domestic violence and how to deal with this training, the healthcare provider can identify it, but it was too late. So such type of training can always impart the healthcare provider to identify it so early so that they will not cause any harm to their life. Next slide. Now there are certain signs and symptoms which were taught to us, and even the on-site training was given. They were one of the indicators for domestic violence. For example, a woman is coming with repeated abortions. We used to offer her safe abortion practices. But when we do a sensitive inquiry into that, it is found that she was repeatedly remaining pregnant because the contraception was not in her hand. She's facing the violence at home and there is no decision making. So either the pregnancy is not detected earlier or she is coming so late for the termination of pregnancy because of domestic violence. So this was one complaint where we can probe and we can find out the domestic violence. Second is that a woman coming with repeated vaginal discharge. So she is getting treatment, but still her OPD attendance is not decreasing. This is another reason where we can think that she may be suffering from a domestic violence or a sexual violence. So when we do a deep inquiry into that, initially they are not opening up, but gradually once they get a faith in us and trust in us, they open up and they give the history of domestic violence and sexual violence, and they are treated. So this is the health impact which a domestic violence and sexual violence is occurring. So if we can sensitively handle this, definitely woman is benefited. Next slide. Now, forms of violence in our India, in Maharashtra, what we have seen is that the emotional violence and the physical violence, it is 74% and 64%. The sexual violence rate is little less, it is 22%. Why? Because in India, in Maharashtra, the sexual violence is considered as a stigma. So they are not opening up directly saying the sexual violence, but definitely they are there underlying it. But the emotional and the physical violence was the most common one. Next. Now, woman-centered care. Now we have been taught to give a lives approach. So in lives approach, most of the women, around 75%, they got a 3 first initials. That is listening, inquiring, and then validating. This 75% of healthcare provider use this. Remaining ES, that is enhanced safety and support, was used by little less, that is 27%. Why? Because it requires a dedicated healthcare provider. It requires a proper training and it requires time also. But we could give out of lives LIV in 75% of the women. Next slide. Now, what lessons we learn after this? Because before imparting a training, we were not knowing about the domestic violence and sexual violence inquiry in the healthcare. But with this, we have designed a curriculum along with the Sehat and WHO, and we designed a standard operating procedure under which all the chief complaints, all the sensitive issues, and whose work is what is all destined. So there is a crystal clear clarity, so that every person is identified regarding his jobs. So that made very easy to sensitively put your probe in this violence, and it is considered as a routine part of work. It is not considered as an overburden. Secondly, it is not only the healthcare person as a doctor or a staff who is looking after this. Even the supporting staff and the people around you who are taking care of the woman, they are also important. So even their training is also given, and they are also participating in women addressing this issue, and that has given a positive impact. Next slide, please. Now, another important thing which came out of this, that the training which we received as an administrator, as a HOD, we have given an on-site training at the healthcare facility. So at Medical College Aurangabad, we have given on-site training to other healthcare professionals, our assistant professors, associate professors, our staff nurses, and the supporting staff. So what is that has made that this on-site training has not only cleared our idea, but also they made the things very possible, and a team is acting here. So what as a team we did that, when a woman is coming for any violence, most commonly, most of the time when they are coming with a sexual violence, sometimes there is a child of less than 18 years. So here the woman is being examined as a team, because it requires a group of people like a gynecologist, forensic specialist, psychiatrist, and pediatrician. So all are coming one-stop center like activities going on, so that the girl is given a full support, emotional and physical, and then she is being examined at once. So she is feeling that it is like our home, and she is opening up with her all problems, and she is being counseled and supported in future also. Next slide. Next slide. So this has led to give us a woman-centered care, woman prioritized care, in spite of all other clinical work. Due to the training of this domestic violence and sexual violence, we can go do the justice to the woman. Thank you very much.
Thank you very much. Sorry, we are running a little bit out of time. And if you have questions, please do post them on the live Q&A. And even if we might not have time to reply, you can always write them to us, the chairs, and then we will distribute it to the speakers. So our next and last speaker is Dr. Akmal from Afghanistan. Dr. Akmal, you probably have you have to stick to the time to 5 minutes just to make sure that the session doesn't interrupt. Thank you very much.
Thank you very much and good afternoon. Just for information, Afghanistan is implementing gender equity in rights program from 2008, In 2014, I'm going to a little bit go to background. In 2014, Afghanistan was the first ever country coming to GBV technical protocol development and endorsed, and also for the implementation mobilized almost 10 million USD and implemented the project since 2015 up until 2020 in almost 7,000 healthcare provider trained. Privacy and confidentiality ensured due to distribution of curtain and gowns. And so that is, and the next step, our next step is we always cover the public sectors, but now it's planned to expand the current project to private health sector and also community engagement. One another announcement, Afghanistan in 2019 also developed the GBV an emergency health response to GBV strategic plan. It means strategic plan for GBV in emergency. Also Afghanistan developed to mainstream GBV in emergency setting. Just for your information. So the protocol for 5 years. So the protocol or the project implemented in 3 phases. For each pages, we conducted a baseline assessment and inline evaluations. So one of the assessment, baseline assessment, we just want to share the result. And the main objective of the assessment was to assess the current capacity of healthcare provider and identify the health facility readiness and existing gaps in health facility to provide health response to GBV. Next slide, please. So the study was qualitative and quantitative both, and it's covered 5 areas. What is the existing practice? What are challenges and barriers toward the GBV health response to GBV? About healthcare knowledge, healthcare provider knowledge and attitudes, and institutional framework and infrastructure readiness. Next slide, please. Sample size was 208 health facility observations, 795 face-to-face individual interview with medical doctor, nurse, and midwives. And even though it was not in our tools, but the NGO who is implementing the assessment, also it covered 1,400 client exit interview with women and 14 in-depth interview with health facility managers. Next slide, please. So in the finding, there's a lot of finding. We just focus on a few. Availability in observation in health facility, availability of private examination room, 72%, type of policy documentation record keeping, 13.2%, female healthcare staff was yes, 93%, job aids for health facility staff and GBV, 4%, existing referral mechanism, 11%, and IEC material related to GBV was 12.5%. Next slide. About the knowledge, again, there was a lot of things, a lot of questions, but just we are focusing on a few. So there were questions about emergency contraception should be given with 120 hours after rape. Only, believe me, 0.6% responded correctly. So it means there was no capacity or very lack of capacity about these issues. Emergency contraception should not abort pregnancy, only 34% said correctly. Information about GBV survivor cannot be shared without his or her permission, 84%. Next slide, please. So there was a lot of problem about attitude of healthcare providers. 74% believe that female patients feel offended if asked directly about violence. 89% believe that majority of survivors will deny that they have been abused even if asked. The last, which very worse, believe 84% believe that sometimes being abused or assaulted is the woman's own fault. Yes. How about the practice? So there was also problem in the finding about the practice. Availability of female staff to accompany patient examined by male providers, 72.6%. Asked if women ever presented with bruises or other signs of violence such as repeated STI, unwanted pregnancy, 69%. Asked if women ever said something that indicated being a victim of violence, 73%. Next slide. So these were the observation and the knowledge, attitude, and practice. Now also we identify some challenges. There is a big list of challenges. We only focus on a few. Lack of private space for GBV services in the clinic. There was 70% in health facility. There was no private space. Workload, as our other colleagues also mentioned from other country. Time limitations. Most of the healthcare providers said they don't have 55%, they don't have much time. And focus on other health problems that have received higher priority is 68.5%. They said there's a lot of other priority and it was not their their job or term of reference. So they say it is additional responsibility. There was also some cultural issues. For example, they said I could offend women if asked them whether they are experience violence, 73%, and the community might react negatively, 87%. So they are afraid from police, they are from community, they are afraid from police. And they didn't want to engage with this issue. There's a lot of other challenges as well. Next slide. So thank you. There was no time. I may finish in my own time.
Thank you very much, Doctor. This is really helpful. And now I'm going to just leave the floor to Avni for the Q&A. So we don't have much time, but at least it will be interesting to see what questions the participants have asked.
Thanks, Manuela. We have a few minutes only, so I don't know if anyone has questions. Can you post them in the live Q&A? Because even if we don't get to answer them live to you today, we can make sure that we send the responses to you in writing. The question from Tira, Dr. Akmal, is sample size for women and for healthcare providers. I think the answer was 700 plus healthcare providers and 1400 women exit interviews. I hope that answers the question right away, because I think that information was in one of the slides. Any other questions? I don't see any other questions coming up in the live Q&A. Okay. Don't see any. All right. Okay, so we have about 2 minutes before we close. So I'm just going to use the opportunity to maybe summarize the key findings. I think it was very interesting to hear from very widely different settings. We went from Brazil to India and Afghanistan, Palestine, Mozambique, so really different contexts. But I was struck by some of the similarities. I think in all of the trainings, what was interesting is that every one of them addressed the perceived barriers, whether they were time issues, perception of lack of skills, the issues of empathy, etc., and sense of preparedness, which I think all the settings did. In some settings, there was a slightly different approach, where in one setting there was a team approach, in the others there was more of a relying on specialized providers, and the jury is still out on which model works, but I think it's important to flag that. I think what was common across all of the settings was really the attention to system and institutional barriers. Standard operating protocols were put in place, clarifying roles and responsibilities for providers was put in place. Job aids were put in place in some and not the others. The issue of space, the private space for consultation, was identified or addressed. Internal referrals were addressed or identified as issues and then improved. I think the external referrals in some settings was a gap, and community engagement was also identified as an issue. So I think it's important. The other thing that I think was common across all of them was the policy, what I call policy, political, and contextual issues. So I think we identified issues of sustainability, lack of sustainability due to financing and budget cuts. COVID has been a big shadow for all of the settings, fragile settings, as well as not having policies or laws in place, or having them in place made a difference. And then the other gaps, I think, were related to documentation in the HMIS, which was identified as a gap or addressed as an issue. And the other one that I think all settings either identified or explicitly addressed as gaps were cultural attitudes of providers, which was quite critical to address. So I'll stop here. We have 24 seconds. Thank you all very, very much. We realized that, time was short and we were running through a lot of content. I hope that this has been a rich and informative session for all of you. Certainly for me, some of the presentations I'm hearing for the first time. So I was very struck by how there are some commonalities and how there are some specificities that we can learn from these different settings. Over to you, Manuela.
Yes, I wanted also to thank you all the participants and our panelists to be present today with us. And I hope that this discussion is just the beginning, and there will be more, especially in this health systems forum, and that we continue to really do the work and try to integrate services for abused women within the health system and strengthen such response. So thank you very much.